Today we have a guest speaker, Dr. Rahmim, is Associated Professor of Radiology and Physics at the University of BC, as well as a Senior Scientist in Provincial Medical Imaging Physicist at BC Cancer in Vancouver. He received his PhD in Medical Imaging Physics at UBC. Following doctoral studies, he was recruited by Johns Hopkins University to lead the high-resolution brain PET imaging physics program and to pursue research at the Johns Hopkins University Department of Radiology. In 2018, he was recruited back to Vancouver, where he leads the Provincial Molecular Imaging and Therapy Physics program. His lab pursues research in tomographic image generation analysis. He has published a book, over 130 journal articles, 260 conference proceeding papers and abstracts, and delivered more than 90 invited lectures worldwide. He was president from 2018 and 2019 of the Physics, Instrumentation, and Data Science Council of the Society of Nuclear Medicine and Molecular Imaging, and was awarded the John S. L. Young Scientist Award by the American Association of Physics and Medicine in 2016. Dr. Rahmim's topic today is new developments in radionuclide imaging and therapy for prostate cancer. Please welcome Dr. Rahmim.
It's a real pleasure to be here, a real honor actually to be here. I'm actually here with my father-in-law who's sitting at the back, who himself is a prostate cancer survivor. And you know, I've given many lectures, but I was telling him that for me the most distinct pleasure and honor is when I talk to the patients. So it's a real privilege to be here. I'm really truly humbled whenever I do this. The other thing I would like to ask you is feel free to stop me, ask questions, make comments. I would like this to be more interactive than usual. So feel free, please. So here's the topic of my presentation today on really exciting new developments in radionuclide imaging and therapy for prostate cancer. As was just mentioned, I am in BC Cancer. I've been in Canada now for about a year and a half, having returned from the US from Johns Hopkins and sort of continuing that line of research. When I arrived on the scene here about a year and a half ago, there was this sort of major announcement that happened that some of you might have heard at BC Cancer, that it was the second largest donation charitable act in the history of the organization, where about $80 million was donated to, turns out, prostate cancer research. And this is directly related to the exciting developments that I'm about to talk to you about. And I found out soon after that a good part of my startup package, which allows me to do research, came from this anonymous donation. So again, that has really humbled me. So let me sort of share with you some of the important themes that are happening. So there's this new term that is popping up, theranostics, which you can sort of see that it's a combination of the two words, therapeutic and diagnostic. And essentially, what happens is, let me just make sure I get my, yeah, so essentially what we're having is a diagnostic tool that is being utilized to better help us define the right therapeutic tool for a specific disease. So this is extremely natural in the kind of work that we do, which is nuclear medicine. Let me explain that to you. Because sometimes what we have is a certain molecule. Take a look at this molecule, for example. This molecule, a molecule may be designed to bind to a certain protein, for example, that a cancer cell produces. For example, in prostate cancer, there's a protein called prostate-specific membrane antigen, PSMA. Not PSA, but PSMA. You will keep hearing that term, PSMA. That is expressed, that is created by prostate cancer cells. And if we are able to design a molecule that is going to bind to that kind of a expression, that kind of a cell expression, then if you sort of tag that molecule with a radionuclide that emits light, gamma rays, light, then you're able to image those cancer cells. Now, if you instead label that with something that emits particles, let's say beta particles, which are electrons, for example, then instead of imaging it with light, you're actually bombarding it with particles. So this is what we call a theranostic pair, where if you label this molecule with something that emits light, you can, for example, do a PET scan. And if you instead label it with something that emits particle, it sits there, it attaches itself to the cancer cells, it sits there for tens of hours and bombards the heck out of it with these particles and tries to kill the cells. So this is what we call a theranostic pair, where you can do imaging and treatment. So the idea is treat what you see and then see what you treat. So first you see the cancer, then you treat the cancer, then you come back and see if the treatment is working. So it's a very exciting new paradigm. So imagine you've got a number of patients. A fraction of those patients might be expressing those kind of proteins, or their cancer cells are expressing those kind of proteins. So we're able to target them. So first we do, let's say, a PET scan. We see those patients that have those targets. And then we select just those patients for therapy. And then so this is what's called targeted therapy. So again, this is sort of, you might have you heard of the expression, the term personalized medicine, precision medicine? These are sort of new things people talk about. The idea is we're not going to just give the same treatment to all patients. We're going to subselect a group of them, and then we're going to sort of personalize therapy for those patients. So let me talk to you a little bit about the PET scan. I'm a physicist that works on, especially in PET imaging and also SPECT imaging. These are nuclear medicine modalities where, for example, you inject a patient with a radionuclide, and this radionuclide, this molecule that has been labeled with a radionuclide goes, finds its target, let's say cancer cells, it sits there, and you're able to visualize for example, the cancer. So the idea behind it, if I may get a little bit technical, is that you've got a parent nucleus, which is a little bit unstable, and then it emits to so-called daughter nucleus to become more stable, but meanwhile it emits so-called positrons. A positron is like a positive electron. And then the positron actually combines with an electron, and suddenly the two of them just annihilate. It's like the classic Einstein E equals mc squared. You've got matter, which is positron and electron, and they disappear, and they give light. They create these gamma rays, these lights that essentially come out of your body. And then if you've got detectors around the body, then it is able to see these two gamma rays that are kind of going in opposite directions, and it is able to say, it's going to say, I just got one here, I just got one here. I'm going to connect that line, create a line, because I know that this event must have come from this direction. And then you do this along all, you sort of surround the patient with detectors all around, kind of like MRI, CT. You've got coverage. And then that allows you to reconstruct and to generate the image. So the idea typically in a PET scan is a patient is injected at time 0, and then the patient sits, and some of you might have undergone this, a patient sits there for about 60 minutes, and a typical PET scan is done using so-called FDG, fluorodeoxyglucose. It's basically radio-labeled sugar, because in cancer, metabolism increases, right? So essentially, if we're able to visualize the human body, how fast it's using sugar, it's using glucose, we might be able to find the tumors, because tumors utilize glucose faster than normal cells. So essentially, you're radio-labeling sugar, injecting it into the human body. You let the patient wait there for 60 minutes, and then you put them on the PET scan, and you sort of image where this metabolism is happening faster. So again, the fluorodeoxyglucose, the radiolabeled sugar, is first in the blood, in plasma. It enters the body in the tissue, and then finally it sort of gets trapped in the tumor. It sits there, and we're able to, for example, image hot spots.
Yeah. Does that mean that your blood sugar level would go down?
You mean
if cancer cells are using
yeah.
faster? Does that mean you'd have a lower blood sugar?
That's a pretty good question. So when you inject the patient, it goes through, the tissue takes up the sugar from the blood anyways. But your question is, when there's higher utilization of sugar, does that mean your blood as a whole goes down? That's a pretty good question. I think it would depend on, it depends on the load, the tumor load. If you've got a couple of tumors here and there, that's almost nothing compared to the total usage of the glucose. For example, yesterday I was thinking so much that I knew that if I do a PET scan right now, my brain's going to light up because, I just knew it. I just sensed it. And it actually happens. When you do a PET scan of the human, the brain is one of the hottest spots. Our brain uses a lot of glucose. So when a clinician reads PET images, it knows that certain parts of the body use glucose a lot anyways. So they're not going to call that cancer, right? So I think already the body is using a lot of glucose and sugar, that having a couple more tumors doesn't really change in that sense that you're talking about. Great question. So again, the idea is if you've got a malignant cell that's taking up this radiolabeled sugar and you've got detectors around it, you might be able to just visualize it. So typically a PET scan these days, in fact, nearly all PET scans these days are combined with a CT scan. Because a PET scan sort of gives you this thing that kind of looks like a ghost. You don't exactly necessarily know some of the anatomic detail, but CT gives you anatomic detail. So CT scan tells you where all the exact organs are, but a PET is really showing you where the body's utilizing glucose faster than the rest of it. So you would see the bladder, again, lighting up. See the brains lighting up? That's what I was just telling you. But then you've got other stuff that might indicate, for example, cancer. And then you would fuse them together, and you get a PET CT image, and a clinician sits there essentially and sort of tries to assess disease. And so a typical PET CT scan, you first do a quick CT, and then you do the PET scan. Typically it takes about, let's say, 15 minutes to do the PET scan. Yeah. So let me first start by something totally unrelated to prostate cancer, and hopefully you'll see why. I want to talk about first neuroendocrine tumors, which is a much less prevalent disease, but because this field of theranostics first really started with these kind of tumors and now is really coming to prostate cancer, I'd like to talk about this a little bit, sort of explain the field to you, and then show you where the real excitement is for prostate cancer. So essentially, in these kind of tumors, they express a certain kind of receptors. And again, so if you've got a certain molecules, we call those DOTA-TOC, for example. These are sort of peptides. A peptide is like a small molecule. That these, again, go and bind to these receptors that are created, expressed by these tumors, and then you're able to image. So this is a PET scan using this kind of molecule that is looking at neuroendocrine tumors. Sorry, this is actually a regular PET scan, an FDG PET scan, but this is that special kind of new scan with DOTA-TOC. You can sort of see that the PET scan, I mean, we're not physicians here and necessarily can't read this well, but you can sort of see that the stuff that is being sort of lighting up here, I'm trying to get my cursor to work here. Yeah, you can sort of see that more stuff is lighting up here that you may not see in a regular PET scan. Sort of see that? So a regular PET scan does show certain hot spots, but doesn't really show much here, for example, in the liver. But here, this really showing a lot more because, again, it's targeting those kind of special cells. And a PET scan for this kind of imaging is very sensitive in detecting tumor, like 97% sensitivity, whereas in CT, for example, sensitivity is much lower. So you would be missing a lot of positive tumors. And also SPECT, which is another kind of nuclear medicine modality, but lower resolution. But so you can sort of see where the excitement is with PET scans. Now, so again, I keep talking about theranostics. So there's an imaging part, there's a therapy part. So just hang in there with me. One of the problems with this therapy thing is that it has too many names. There's too many different names for the same thing. So there's a bit of a confusion. So I've tried to list some of the different names for the same thing. So some people call this radionuclide therapy, or targeted radionuclide therapy, or radiopharmaceutical therapy, or radioligand therapy. And nowadays, I kind of like this last one, molecular radiotherapy. You've heard of radiotherapy, where you got these external, beams shining essentially X-rays through the body. But molecular radiotherapy, the concept is instead of the beams coming from outside, the radiation comes from inside. You inject a patient with a radionuclide, and inside it goes, finds the tumor, sits there, and bombards them, as opposed to a typical radiotherapy, which obviously is a very active program here. And again, many of you might have experienced that, where the beams come from outside. So again, you've got certain molecules. These could be large molecules like antibodies, or small molecules like peptides. This is where the real excitement is these days, because small molecules sort of get to the tumors more easily. And again, the idea is if you've got a tumor that is expressing a certain kind of protein, and you've designed a molecule that goes and finds these proteins and binds to them, and then that molecule itself is tagged with a radionuclide that either emits light for imaging or emits particles for therapy. Does that kind of make sense? Okay, so again, feel free to stop me, please. And again, it sits there. So we've got here are examples of certain radionuclides, like yttrium-90. It's a radionuclide that emits particles, or iodine-131. Iodine has in the past really been used for thyroid cancer and things like that, but it can also be used but that's what it's really known for. So another one that is very popular these days is lutetium, or lutetium-177. Again, so these are radionuclides that emit particles, emit electrons that are bombarding the cancer cells. I want to show you another example that is, again, totally unrelated to prostate cancer, but just to explain to you what, yes?
Is this similar to brachytherapy?
That's a fantastic question. Similar in the sense that the radiation is coming from inside.
Yeah.
Different in the sense that in brachytherapy, you're sort of implanting hot stuff in the body, whereas in this case, you're just injecting it to the body. So that's kind of so fantastic question. So brachytherapy is kind of like internal radiotherapy, as is this, but in brachytherapy, it's more invasive. You've got to go in there, you've got to insert these seeds, for example, whereas in this case, you're not. You're injecting the patient. Fantastic question. So I want to talk to you a little bit, again, about this area, which is called radioembolization for liver cancer, or they call it selective internal radiation therapy. I just want to show you certain themes where radiotherapy is not done from the inside, not from the outside. So again, these are really exciting areas now used extensively around the world. So when somebody has liver cancer, one interesting approach is that again, this is kind of invasive, but they actually insert some catheters, and then they literally inject these beads, which could be like very, very tiny sort of glass microspheres that have radioactivity in them. They inject them directly into the liver, and it's kind of invasive, but it sits there, and the way these beads or these glass microspheres that are hot radioactively, they go in there, they basically occupy the vessels leading to the tumor, and they just sit there. They just sit there for tens of hours. So they're kind of trapped in these vessels, and they're doing a couple of things. First of all, because they're sitting there, they're creating these radiations, these particles, so they're bombarding the tumor. Plus, because they're in the vessels, they're kind of disrupting delivery of blood and oxygen to the tumors, and they're sort of suffocating the tumor. So they're sitting there, suffocating the delivery of sort of nutrition, let's say, call it, to the tumors, and they're bombarding it with radiation. So sort of a very effective area is really making a difference in liver cancer patients. So again, another example where radioactivity from inside the body is bombarding the tumors. So let's talk a little bit more about this field, which had many different names, but I'm going to call it, for example, molecular radiotherapy, right? So again, I'm just recapturing what I told you. The idea is you inject a patient. Well, you don't inject to the chest. That's kind of a misrepresentation. You typically inject into the arm. And then it goes all around the body. It finds the tumors that are expressing that kind of protein, and it just sits there for tens of hours, right? And it's pretty safe for the people around you because, yeah, it is bombarding the tumors, but it's a sort of more of a local bombardment. It's not doing things much outside. There's only a little bit of. It's pretty safe in that sense from a radiation perspective. And then again, it differs from external beam therapy in that external radiotherapy you come from outside, whereas in this kind of molecular radiotherapy, the radiation is coming from inside. Is that okay? So again, showing you example of neuroendocrine tumors. Here's a patient with very extensive disease. See, anybody can sort of see that this patient is not doing well. The tumors all over the body. And by the way, do you think you can do radiotherapy, external radiotherapy on this patient? I mean, it's almost impossible. But what are you going to do? You're going to target everything from outside. Very difficult, right? So that's not even an option. But with this approach, you just inject. It goes throughout the body, finds a tumor, sits there. And look at how this patient is doing 22 months after this is done. You see, there's a big difference here. There is something still here, right? But I mean, there's a tremendous improvement. So clearly an impact on survival. And this drug, for example, has been approved now in the US. Again, neuroendocrine tumors, not prostate, but this was just approved by the FDA in the US, for example. This is a plot that you might have seen a lot. This is called progression-free survival. So essentially, you track hundreds and thousands of patients over months. And this is a typical drug that they give to these patients. So you can sort of see that after 25 months, almost all patients have progressed. The disease has gotten worse, right? So the survival is not good. Progression-free survival is when progression. We're not talking about death. That's called overall survival. So here, these vast majority of these patients have progressed. The disease has gotten worse. But this is what happens to a different set of patients when they get radionuclide therapy. You can sort of see that they're doing much better. Over half of the patients have not progressed in disease. So it is really making a big difference. And again, just to finally show you another example, this is again that small molecule. It is going to target the cells. It is tagged with a radionuclide that is emitting either light or particles. And it's going to essentially sit there, bind itself to the tumor, and bombard it with electrons, bombarded with particles. And sort of this illustration is sort of saying it's going to sit there and try to kill the tumor. So that's a kind of an idea. And at the same time, sometimes, or before or after, you could also image this because some of these things emit both particles for treatment and light at the same time for imaging.
How long does that last in the body?
So the typical so-called half-life is about tens of hours. So it takes about, let's say, tens of hours, it sits there. And then after tens of hours, depending on which one we're using, the body gets rid of it and so it's gone. Yeah. And then typically patients do about kind of like chemotherapy where you get sort of, let's say, 4, 5, 6 cycles. In here too, you typically get maybe 4, 5, 6 cycles. Yeah. Now, I want to talk to you about the yes?
So going back to the slide you showed
Yeah.
of where the before and after of how the tumors had decreased, there's so few,
This one? Yeah.
Yes, there's so few tumors left. Does that make them now susceptible to external radiation therapy?
Fantastic point. I think so. That's true. So people are now the new paradigm. I mean, this whole paradigm is kind of new, that people are exactly asking what you're actually thinking like a scientist right now, exactly. So they're saying we should be combining this technique with external radiotherapy. We should be sort of, so for example, when you have adjuvant therapy, you've got, things working together, radiation with chemo, people are saying, well, maybe internal and external radiotherapy should now be working together to tackle this. Fantastic question.
The other thing
Yeah.
in the news is the radiation products are becoming less accessible to hospitals and to research.
less accessible because of all the patenting or whatever that's going on?
Or also there isn't enough being produced.
Oh, I see. Yeah, yeah.
And there was something came out in the news that now internally in hospitals they can get a machine and
Yeah.
reproduce it.
So I think the demand is going up, and there's just not enough to meet the demand. In fact, I have a few slides towards the end that sort of talk about that. So thank you, Bob. That's a great point. We'll come back. Remind me if I don't come back to it, because I want to talk about that. In fact, this is an audience that I really want to share some of those thoughts with. So this is where a lot of excitement is in prostate cancer. I mentioned to you already about PSMA. You will keep hearing this word PSMA a lot. Everybody here knows, I think, knows about PSA. These are things obviously we, every prostate cancer patient I think is really sort of focused on what the PSA levels are. In the not so distant future, I believe PSMA is going to be an important term that people are going to be really tracking. So what is the concept here? I already sort of mentioned it. Prostate cancer cells, over 95% of them create these kind of proteins, PSMA. PSMA is a protein produced by majority of prostate cancer cells, and they're overexpressed, overcreated in prostate cancer. And they're really correlate with aggressiveness. So the more of it that you have, the more aggressive the tumor is. So again, if you have a molecule that can bind to PSMA, and the molecule itself is tagged with either gamma, which is light, for imaging, like a PET scan, or with beta, which is particle for therapy, you've got a very important theranostic approach to prostate cancer. So here's an example of a PSMA. So I kept showing you examples of FDG PET. These are the radio-labeled sugar stuff. But this is a new paradigm. The new paradigm in PET that everybody's excited about is doing PSMA PET imaging. So this is a so-called bone scan, which again some of you might have had. And this is another kind of a sort of a conventional PET scan. Sort of see stuff here and there, right? But then this is a PSMA PET scan. So I mean, you sort of see stuff here, but the PSMA just gives you a lot more detail into the body. So again, clearly you see this patient, the disease is a metastatic case, obviously. This is a radionuclide that actually was designed at Johns Hopkins University, where I was by my boss, the head of my division. And it is expected this radioligand, pharmaceutical, will be approved by the FDA probably in 1 or 2 years. I was having a conversation with a urologist a few weeks ago. He said, I expect that in the future, every single prostate cancer patient will have a PSMA PET scan, because it just shows so much. It is so sensitive in discovering and finding tumors as they present themselves. So I want to show you some examples. Yes?
At what stage would that happen?
So right now, this is happening when, especially for metastatic castration-resistant prostate cancer. That's where the paradigm is. But people are starting to think about doing it earlier. So we have research studies going on ourselves also trying to ask that question. I'll show you some examples. Yes, please.
The question is based on the fact that I've been in the prostate world as far as being exposed to it for 20 years.
Okay.
My son is also in the UK, and him and his wife are in cancer research. My son works on machines.
Mm-hmm.
One of the things that he does is software development and everything is called Machine Maker,
Which is somewhat, yeah.
which he would use. The experience has been, and you're talking about everybody within a couple of years having this scan. My experience is that's not going to happen.
Yeah. And tell me why. Yeah.
The reason is I can't even get in the public system a prostate cancer MRI for a year. So if you're telling me that everybody's going to have one of these, I think you're dreaming.
Yeah.
Okay, that's just my experience.
No,
I can get a prostate cancer scan within a week if I pay. MRI. Okay. And now the government's trying to cut that out, which hopefully they won't be able to. So that's my experience. So
Yeah.
what do you say about that? I mean, this is all very interesting and all,
Yeah.
all great, but
Yep. What I say to you is I cannot agree more. So Therefore, it seems like I'm contradicting myself. In a sense, we're supposed to be, as scientists, we tend to be optimistic. We say every person should have it. And sometimes instead of saying should have it, we say will have it. And then realism hits in, as you just did. So I agree with that. And in fact, I have some slides towards the end about the sort of really difficult problem we're having in BC about the low number of PET scanners that might even be available. I'll show you some statistics that would actually sort of really agree with what you're saying. So I agree with you.
Okay, so I have one last question.
Yes.
Where can I pay to get it done?
Yeah, so that's the other thing. You know, in the province that we live in, majority of healthcare is delivered by the government. And I know that there is one center here that is private. There's one south of the border, we have two. But that's exactly the challenge right now. First of all, PSMA is not available in some of these centers. And if you could wait for me, I have some slides to show about this, because I will have some thoughts, and I want to come back to you. Please, I look forward to that discussion with you. I'm going to show you some statistics, actually, about that. So here's an example of a PSMA therapy. So again, the therapy is when the particles are coming. The imaging is when the gamma rays are coming. So here's an example of a prostate cancer patient. Sort of see disease here. And then this patient, this is, for example, year 2013, December. This patient is undergoing cycles of PSMA therapy. You sort of see 1, 2, 3. Looks as though the patient is doing better, right? Even to us. Sort of the disease burden seems to have declined. Just one example. I'm going to show you some dramatic examples. Here's a dramatic example, right? We've got a patient 2014. These patients often are metastatic castration resistant. Nothing is essentially working, right? And so sometimes the patient might have only months to go, right? And then this thing shows up. And it works well on at least a good number of patients. Goes through cycles. 2014, December. 2015, 6 months after. Right? I mean, it's a major response that you sort of see. Also look at the PSA levels. 387. And then here we're looking at 1. Right? So clearly, and again, nothing else would work on this patient. Right? Radiotherapy is out of the question. Androgen deprivation, these things are not obviously working, so it's castration resistant, right? So there was this, and this field has really been led by a number of groups, but especially the Germans and the Australians have been very active in this front. In fact, we've got people from North America in the past and even present. You ask the question, where do I get one? Many people would actually fly to Germany and to Australia to get these therapies, right? Because it was not being provided. Yes?
One thing I will mention is that my son, who's in the UK, works extensively with Zeiss.
With?
Zeiss.
Okay.
In Germany.
Right. Yeah. So I want to share with you one of the trials that excited a lot of people from Melbourne. Not a big study, about 30 patients, but a lot of excitement. So this was done on about 30 patients, and they wanted to simply see. The endpoint was PSA response. When we do PSMA therapy, right? I mean, that term should be clear by now. Is that okay? PSMA therapy. When we do PSMA therapy, how would it impact the PSA levels, right? So here's an example of how the patients responded. These are PSA levels after therapy. 97% of the patients had a decline in PSA levels. You see the PSA levels are going down by a couple of percent here for some patients, all the way up to 100% decline in PSA levels. So very, very good response. More than 50% decline in so the PSA dropped by more than 50% in majority of patients. PSA levels dropped to very low levels for some patients. And this is the kind of awe-provoking pictures that we got. This became the picture of the year in my Society of Nuclear Medicine. This is an example of 8 patients. 1, 2, 3, 4, 5, 6, 7, 8. 8 out of 30. This is before, this is after. The red stuff is cancer. So you sort of see all over the body, nothing else is working. After therapy, this is what we're seeing. And look at the PSA levels. We've got 146 going down to 1. We've got 967 going down to 7. So in some cases, the disease doesn't seem to be present anymore. In some cases, it's still there, but clearly significant decline. And there's many studies going on sort of to study how this impacts survival. Obviously, it's anticipated that it will prolong survival. It might treat some patients. It might really impact, for a number of patients, significant impact.
Have you got a history after the treatment?
Yeah.
Does the cancer start growing again? Or
right. So that's exactly the kind of studies that are going on right now, because this kind of therapy is relatively new. So in some sense, some of these are referred to as palliative, but it is so dramatic that you don't even know what to call it. Because even if it comes back, we're talking about, a lot of these drugs that show up in the market are approved by FDA. They're extending life by 1 or 2 months, and they're adding a lot of difficulty and suffering to the patient. We're talking about potentially years here, if not treated. So it's very significant. Does that, yeah. And in all patients in this study, there was some pain relief, because 90% of the patients had pain, and all of those patients who had pain had some kind of pain relief because of this therapy. There are some side effects like nausea, dry mouth, things like that. But still, dramatic. So I want to talk to you a little bit about the PET program that we're having at BC Cancer. So I was recruited to lead the physics program in the province. We have 2 PET scanners here in Vancouver, and then we have one that was just installed in Victoria, and one coming up in Kelowna. I want to talk to you about those statistics, which are not impressive in BC. We definitely need far more PET imaging in this province. But just to share with you what's going on here, so we scanned so far about 80,000 patients in the time this program has been around. I think this is since 2005. And there's a bunch of clinical trials going on. This is the PSMA imaging that I mentioned to you. I'll show you some results of that. Again, I'm back to imaging now, not therapy. So PET imaging. So this is the PSMA imaging. This is the neuroendocrine tumors that I mentioned to you. A number of studies going on. And then there's this place in Vancouver, you might have heard of it, Triumph, which is the particle accelerator. Clearly, these places have a natural ability to design and to work with exciting radionuclides, labeling the molecules. So actually, Justin Trudeau was here. I think this was about a year ago. He visited Triumph, and this is a tweet by him, and he literally mentions nuclear medicine. He was here for that, for nuclear medicine. A lot of excitement around there. In fact, it's an interesting picture because this individual is a chemist, Tom Ruth. When I was here at UBC doing my PhD, he actually trained me. And here we've got Paul Schaefer, a new sort of young, energetic radiochemist at Triumph that we're working together. So a lot of excitement, a lot of investment in this area. So in our PET center, we have, as I mentioned to you, we have different, we have PET scanners. We have a cyclotron that typically produces that radio-labeled sugar that I mentioned to you. But now we are also doing PSMA, for example, for imaging. And let me just share something else with you. Oh, how am I doing in time? I am kind of speaking slowly, but is that okay?
We'll listen forever.
Okay, because yeah, I have a few. Okay, thank you, I appreciate that. So again, we have done extensive imaging, PSMA PET scans. We've done about 600 of them so far in Vancouver, and I just want to share with you some of our findings. This was an initial assessment on 130 patients that were done here at BC Cancer, PSMA imaging using PET scan, right? And what they showed was that simply that image changes stuff. The physician being able to look at a PSMA PET scan of a prostate cancer patient in 2/3 of the time, just by having that PET scan, the treatment intent changes. So it's very important. 2/3, that's significant, right? It's almost like we've been blind so far. And now we have not just PSA, but PSMA. And that allows the better decision making. So the stage of the disease changed in 2/3 of the patient, and management changed in the vast majority of the patients. So just by having that PET scan, the thinking about what therapy should be done changes. And then we've done more and more studies, again, over 600, but this analysis I have is about 500 patients. About 10% of patients had some mild adverse events after the scan, but all were resolved complete. So it's pretty safe scan, the PET scan, not the therapy. The therapy is pretty good too. So here's an example of the relationship between PSA and this is PSMA. This is an important plot. What this plot shows is that, for example, if the PSA levels are very low, obviously you're going to have less patients that also you will find tumors on their PET scan. And the higher the PSA levels, well, you're going to find more tumors in the body. But it does also say that they're not exactly directly the same thing. For example, you could have very low PSA and still have a finding in the PET scan, or you could have higher PSA levels. For example, somebody might have a PSA that's higher than 2. They may get all worried, but that patient might actually be negative from a PET scan. At this point, PSMA PET scans are being given to metastatic castration-resistant patients. And these are patients whose PSA, who, for example, have had radical prostatectomy, and then PSA has gone down, but then PSA has started to go back up. So those are the kind of patients that typically enter these trials. So again, a number of therapies going on here in prostate cancer. I'm going to show you some more. So here's an example of a clinical trial right now going on around the world, including at BC Cancer, of PSMA therapy. It's called the VISION trial. So some patients are being put on this therapy. Some metastatic castration-resistant prostate cancer patients are being put on this therapy right now, and it's being studied. And it is anticipated quite strongly that this will be a very effective therapy, as the evidence seems to be suggesting. I want to talk to you a little bit about another kind of therapy. I've been talking to you today mostly about bombarding the tumors with electrons, with beta particles. But there's also this other kind of particle called an alpha particle. An alpha particle is the nucleus of helium. The nucleus of helium is far more heavier, about 8,000 times heavier than an electron. So if instead of bombarding the tumors with electrons, with beta particles, you're bombarding them with alpha particles, which is the nucleus of helium. Because it's such a heavier material, it might be able to do greater damage to the tumors. So it could do double DNA breaks, so it could really try to disrupt the cell reproduction more effectively. And again, this is an example, and you're going to keep hearing this term, actinium-225. Actinium is something, for example, in TRIUMPH they're trying to make, where it emits alpha particles instead of beta particles. Again, a lot of excitement. Look at this patient. This was a study done in Germany. They're, of course, showing the best examples. That's sometimes an issue, right? They do therapy, but they show the best examples. But these best examples are so amazing, miraculous-like, that they just created a lot of excitement. This is a patient, obviously, with disease all over the body, right? And PSA is 200 here, 300, and it's very extensive. They do beta therapy, beta particles, typical PSMA. Doesn't seem to be working. In fact, things are sort of, the disease is progressing. And then they switch to alpha therapy. So instead of bombarding with beta particles, they're with alpha particles. And they do a couple of cycles and look at what happens, right? So the PSA is now less than 0.1. So an example, I'm going to show you another example. Again, extensive disease, so some cycles of PSMA therapy using alpha particles, and here we are. So a lot of excitement, but there's shortage of actinium in the world. I think TRIUMPH is trying to place itself as a provider of actinium. There's a lot of research going on. Yeah, so that's that. And Do we have any questions so far? Because I want to switch gear a little bit. Yeah.
The ACTAM,
Yeah.
understand you need a cyclone, big one to do it. And
Yeah.
I understand UBC is one of the few centers that has one.
Exactly. 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 So that's sort of what could make Vancouver unique in that sense. And yes. Yeah.
In chemotherapy, there's damage to the cancer cell, but also to
Right.
healthy cells.
Right.
Is there any damage to healthy cells?
So here there is, but because the uptake is so much higher in the tumor versus normal tissue, this is because it's so specific to cancer as opposed to non-cancer, it can be quite effective. But yeah, we have those. So for example, let's say in some of these radionuclide therapies, the kidney takes up some activity, normal kidney. So the kidney is then would be referred to as the organ at risk. So then you cannot inject too much because you're going to damage the kidney. So that's exactly what some people do, and this is an active research in our group too, dosimetry, where you're trying to give the patient as much as you possibly can without damaging the normal organs. So these are exactly the kind of considerations that you have to have. So I think I'm just going to quickly talk to you about a little bit of efforts that we're having on artificial intelligence and how that can apply to this whole sort of paradigm. In our group is highly active on that. I just want to sort of share with you some thoughts. Typically, a PET scan is read visually by a clinician. They look at the PET scan. They have obviously knowledge of which organs typically take up activity as opposed to abnormal activity. But I think AI machines might be able to sort of detect subtle changes in the body that a human may not be able to observe. And also, tumors may be heterogeneous. Here's an example of a tumor that takes up, shows in a PET scan as being heterogeneous, being non-uniform, whereas this is more uniform. Well, up to now, typically, you don't really think about it that way, but actually it turns out if a tumor is heterogeneous, it probably will have poorer outcome. Why? Because certain tumors become hypoxic. You might have heard of that before. A hypoxic tumor is a tumor where, for example, the center of the tumor, because there is not enough delivery of oxygen to it, the center of the tumor starts to switch to a different kind of breathing metabolism. It becomes more resilient because it's being deprived of blood and oxygen. It starts to change and become hypoxic, and actually that makes a tumor more resilient. So if we're able to sort of use these artificial intelligence methods and quantify how heterogeneous these tumors are, we might be saying, wait a minute, I want to treat both of these, but I probably should be delivering more radiation to this tumor than to that tumor because this is a hypoxic tumor, for example. It needs more radiation. So examples of how we're trying to use AI to sort of look at images differently. You've heard of many omics, so genomics, proteomics, metabolomics. So lots and lots of things extracted. But now in radiology, when you're looking at an MRI, CT, PET, people are referring to this thing as radiomics, where you take a PET scan, you don't just look at the volume of a tumor, you actually extract a lot of features about that tumor. How spherical is it? How heterogeneous is it? And that kind of information might be able to predict the outcome of the patient a little bit better. And if you're able to predict outcome for patients better, we might be able to change the therapy a little bit. So I'm going to skip over these. Presently, current practice, a radiologist sort of looks at an image and sort of annotates it. But the sort of a paradigm we're pursuing here is, the images would be, automatically analyzed by some of these machines. The tumors will be discovered, the organs will be segmented, and then you would be extracting a lot of features, combining those information with medical data, maybe with genomic data, and then you're going to come back with a recommendation. These AI machines, these artificial intelligence machines, are going to come back, make a recommendation to the clinician and say, hey, I believe for this patient who had this PSMA PET scan, you should bring this patient back sooner than later. Or you should, for example, escalate the therapy. Or you should do this, do that. So this is kind of very active. I'm just sharing it with you. This is active research. This is nowhere close to realization in the clinic. But I just wanted to share that with you. Finally, this is my final 2 slides. I want to share with you some statistics coming back to the questions that were asked. This is the number of, in 2017, the number of PET CT scanners in Canada per million people. So Look at where are we on this plot? We're here. We have the least number of PET scanners per million people in Canada. This is 2017. So 0.6 scanners per million people. If you, for example, look at Quebec, where's Quebec? Here, right? Quebec actually has almost twice as much as the population that we have, right? We've had 3, 4, 5 PET scanners here. They have 30, right? So there's big discrepancy between British Columbia and some other parts of Canada. In fact, on average, if you look at Canada, the average in Canada itself is about 1.4 PET scanners per million people. So BC has had an issue. Now, the good thing is in BC, this is 2017. We just got a new PET scanner in Victoria. That's 2019. And we're just getting one in Kelowna. So this number is going to jump up by the end of this year. We have 5 million people, 5 PET scanners. So this number is going to jump up to 1. 1 PET scanner per million. But still, quite far off. And if I would like to compare this to the numbers we have in the US. I just want to create a bit of national urgency here, right? If you look at the US, they have 6 PET scanners per million people in the US. We have 1. So we're looking at about 2,000 PET scanners. This is 2009, by the way. So numbers have really changed since then. 2,000 PET scanners back then for a population of 300 million. So we're looking at 6 PET scanners in the US. Our neighboring US state, Washington State, they have about 4.8 PET scanners per million. In Japan, I did some calculation last night. We're looking at between 3 to 4 PET scanners per million people. So again, I want to remind ourselves, in BC, we have 1 PET scanner per million people. So I think that clearly is an issue, and that is exactly one major burden in future prostate cancer patients getting the sort of routine imaging that they would need. Yes?
I tried to get a private PET scan, and the Bellingham number never answered.
Yes.
And the one in Vancouver couldn't do it because they couldn't get the isotope.
Exactly. So the one, yeah. So the 5 PET scanners that we're going to have by the end of this year in BC, 4 of them are BC Cancer, 2 in Vancouver, Kelowna, Victoria, and 1 is the private one. But the private one, as you just said, I'm not aware if it has PSMA.
I tried.
Right.
Well, not PSMA,
Right.
but it just
Or even a regular PET scan, you mean?
yes, they couldn't get the isotope.
Oh, so I know they've had their own challenges. And this is being recorded, but I'm going to say it anyways. I mean, our government's not exactly favorable to private practice anyways, right? And that's, in my opinion, that's a problem. And as an employee of the government, I'm just going to say it. Our government is anti-private practice, and I don't like that. Because the competition clearly in the US, we see that it has created a good presence of PET scanners. But of course, I know there's nuances to this. I'm not going to create a whole, you guys can probably analyze this better than I can. But I sense, I just want to share this with you, that we have a significant disparity in BC, and that just has to be looked at more carefully. So I'm done. Some key points. Significant summary. Last slide. Significant excitement over PSMA-targeted imaging and therapy. Theranostics, treat what you see and see what you treat. Significant potential, especially for metastatic castration-resistant prostate cancer, but people are looking at for earlier stage also. Lots of imaging and therapy agents going on, expected to be approved for wide usage, but this will really work out on the imaging side if we are able to solve the large disparity that we're having in PET scanners in the province. And I really want to thank you for your attention.
Anybody have any more questions?
I've got one. The imaging and the therapy, the PSMA.
Yeah.
Can that now be done in your trials simultaneously, or is it 2 separate entities?
Fantastic question. So the Vision trial that I mentioned to you, that one does not have imaging. Let me bring it up for you. This one does not have imaging. It's only therapy. It's ongoing. But we have another one that's about to come on board, and it's going to start in 2020. It's called the Pluto trial. That one has imaging and therapy together. because with imaging, as I've been sort of motivating, you can actually sort of look at what's going on, and you can sort of calculate the dose that's being delivered to the normal organs, to the tumors. So we think that the two should go together, so that's why we're starting that other trial. Yeah. Yes?
Where is everyone else getting their isotopes?
Yeah, so that's a pretty good question. There is this company called, so there's a company in the US, what is the name? It's going to come to me. But this company has now patented this product, this molecule essentially, Progenics. So there's a little bit of a sort of a tension going on in the sense that once this thing is patented, which it can be used for research purposes. So technically, these trials that we're pursuing are, when you do clinical trials, you can sort of do stuff with even patented products that we're doing. But once you start doing this routinely on patients, then you've got to go through those companies and get permission and pay them, et cetera. So right now there's two solutions. One is sort of industrial sort of shipping, or locally centers are producing it. Obviously in BC Cancer we're very advanced in that sense. So we're producing our own PSMA. But in other places you have, especially community settings, as it takes off, you're going to have some centralized place in a city that's going to produce it, for example, industrially, and it's just going to ship it to different places. I don't know if that answers.
I just wondered why this private one in Vancouver
He's not getting it. Yeah. Because, yeah, it might be a cost justification thing. Great question. Yeah. Yeah.
Do you work with, okay, this is all scientific stuff here. Do you work with nutritionists or to see what the recovery rate is of people who altered their diet?
Like alternative, you mean?
Yeah, work together to see
yeah.
if people have more nutritional food or certain foods cause cancer.
So I know in our center people sort of try different things and different hypotheses and different alternative approaches. I'm not involved with that. I'm more on the technical side of things, but I know there's a whole bunch of sort of approaches and combination therapeutics is going on. Yeah.
One last question.
Yes.
Is a tumor multiple cancer cells?
Is what?
A tumor multiple cancer cells? Or
As opposed to just one cell? Yes, absolutely. So when you can only see a tumor on a, let's say, a PET scanner when it has many, many cells in it. So that's actually a good question because sometimes you're kind of blind because you do therapy, and after therapy, you do a PET scan and you don't see anything in it. That doesn't mean it's not there. And so that's why you need more and more sensitive imaging techniques. And then looking at, blood sampling, looking at PSA levels, things like that, yeah.
So how would I go about getting onto one of these trials? I pretty much think that
You might be
yeah.
qualifying for it?
Yeah.
So I think my recommendation for you is, for example, that's why I've even shared the BCCA code here. I think you could go to your oncologist and really directly mention that you know that there's this trial going on and another one that's also upcoming, and you would sort of ask them to. And I know there's months of waiting going on, obviously, for these, both for imaging and for therapy. Yeah, that's actually one reason I have this one here. So speak with your oncologist.
What does that mean, BCCA?
I think BCCA is BC Cancer Agency, so it's just a code for this kind of clinical trial, BC Cancer Agency, that is going on. But they'll know. They'll know if you just sort of, yeah,
If
mention
I'm
it.
not mistaken, your oncologist, there's a board, they sit down, they present each case,
Yeah.
and they decide who gets it or doesn't get it.
That's correct. But I think that this patient awareness really is important. Frankly, I do worry that sometimes because of the limitations that I don't know what happens. So I think it's very healthy, obviously, for patients to know about this and to sort of have those discussions with the oncologists and get their feedbacks and insights about it. Yeah.
I got one more question.
Yeah.
Dr. Philip Cohen, is
Mhm.
he working with you or in conjunction with you? Or?
No, I know him. I know him well in Lionsgate, right? So we've talked about PSMA a lot, and in fact, I know he's also talked about PSMA, imaging even on SPECT cameras and things like that. We're not working on this project, but we actively sort of talk about it together. Yeah.
Because I know we had him here as a speaker in 2017, and he was beating his head against the bush, and he told me he finally got a break when Dr. Goldberg at BC Cancer said he started thinking about this. And
Yeah. In fact,
obviously you came back.
In fact, Dr. Goldenberg is a person that is the urologist I mentioned to you that said he expects in the future every patient should or will have a PET scan, which I know there's. So there's a lot of excitement. Yeah, he also came and gave a talk. People are very excited about it, and I think that excitement is healthy because it's going to hopefully push things forward and allow better care for our patients.